You can start, Doctor.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everyone, and Ramadan Kareem. Today we will have continue our challenging cases which we started yesterday, and I'm not gonna go over everything. I'm gonna just start welcoming our moderator, Dr. Ahmed Al-Shahri, consultant medical oncology at King Abdulaziz Medical City, Jeddah, and Dr. Fahad bin Shamsa, also a medical oncology and the chairman in King Fahad Specialist Hospital in Dammam. So without any further delay, I'm gonna give the mic to Ahmed, so we can start our session.
Sure. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone for the second day of this interesting meeting talking about some challenging cases in oncology. Yesterday was the meeting for the breast cancer, and today we're going to talk about few interesting cases in GI cancers. And as you can see, we have three interesting cases to be shared today and will be presented by both of our colleagues, Dr. Ashwaq Al-Alayyan and Dr. Kanaan Al-Shammari. The first case to be presented by Dr. Ashwaq Al-Alayyan and going to be in gastroesophageal cancers. So Dr. Ashwaq, please.
Okay, Shukran Ahmed. I can share it. Okay, can you see my slides?
Yes, we can.
Okay, excellent. So the first case, it's a GE junction case, and what's interesting about this patient is being metastatic and lived for almost 5 years, sorry. He's a 59-year-old with past medical history of coronary artery disease. He's a heavy smoker, no family history of malignancy. He was diagnosed
Ashwaq?
Yes?
Ashwaq? Yeah, I think the slides are not moving.
Not moving?
Yeah, we don't see the details.
Please stop sharing and reshare one more time, please.
مرة ثانية؟
Yes,
طب
and
دقيقة.
select the correct presentation, please.
اوكي دقيقة. نرجع مرة ثانية. Share. واضح؟
Yes, now, yes.
Okay, يلا. We'll go back. It's only a few slides. So this is a 59-year-old who is known to be heavy smoker with history of coronary artery disease, no family history of malignancy. He was diagnosed in another hospital as metastatic GE junction. He was diagnosed early 2017 with biopsy-proof lower esophageal cancer, and we reviewed everything in our hospital. So it was moderately differentiated on the background of Barrett's esophagus. We did everything, HER2 were negative, PD-L1 tests were negative, and MSI stable. I hope that will move. Excellent. This is his initial PET scan. Not really sure if you can see the pointer. I'm trying to make it laser pointer. So if you can't concentrate here, this is the primary tumor. It's huge. And now if you look at the liver, it's very clear, the lesion, huge liver lesion bilobar, and you can see multiple lymphadenopathy within the abdomen. So it's really extensive disease. His patient performance was excellent. I can't say it was zero. Patient, because of mild symptoms, he came to the hospital. So I start him with my favorite protocol, SEX protocol, ibuprofen and cisplatin and Xeloda. During the treatment, the patient developed MI. And he had coronary angio, and also he had a stent. So do you think our chemotherapy causing MI, because that will disturb the whole therapy? This patient on true medication, the anthracycline, as everybody knows, can cause congestive heart failure. But the main trouble with the major medication, which is capecitabine, the 5-FU, which is the backbone of the therapy, it can cause coronary artery spasm or sometimes thromboembolic. So we have an extensive discussion between me and the cardiologist, because the patient carry all the risk factor of having a coronary artery disease, especially heavy smoker. So and also with the history of coronary artery disease, are we exaggerating the things with the chemotherapy? So after the angio and the stenting, he thinks it's really just atherosclerosis disease and it's not related to chemotherapy. So we continue treatment. So post-therapy, can see that the primary tumor is getting smaller, and also the liver lesion, if you can see it clearly, it's also getting smaller. Almost one single lesion left on the liver. So we start the patient post the incidence of MI on Xelox, so he had a good response. Then after that, I kept him only in capecitabine, just a single agent, because the patient is metastatic disease. But unfortunately, on capecitabine single agent, our patient progressed. So we thought, let's go to the second line. At that time, ramucirumab was not available, so I give him just docetaxel as a single agent for 3 cycles. And again, the patient progressed on therapy. I'm not really sure that's moving. Good. So if you look here at the primary going down and down, again, you can see the uptake is less. The liver looks clean, very much no evidence of disease, and also the upper abdominal lymph node. So we thought that still there is some activity within the lower esophagus, but the distant disease almost clear. We've discussed on the tumor board, and we thought, let's go to a less aggressive approach. Let's give him chemorad. Maybe we can eradicate what left on the esophagus. So the radiation therapy agree on us. We know this is out of the box. We start him in chemorad. We give him Taxol and carboplatin on May 2018. He received 50 grain, 28 fraction. And in phase 1, he received 25 fraction. In phase 2, he received 3 fraction. And he completed on mid of June 2018. Unfortunately, after the course of chemorad, and apparently the patient has lost any sensitivity to platinum and also to the taxane, he developed another hypermetabolic nodule in the supraclav, celiac, higher lung lymph node, mediastinal, and developed lung nodules. So at that time, we've run off all the options because very much all the treatment was given to the patient that's sensitive for the gastroesophageal cancer, and PD-L1 were negative, and we know from the attraction trial that we can still give nivolumab in the second line, which is technically is not the second line, but that was the only available option. We cannot give Pembro because we don't have the PD-L1 were negative. So the patient had the immunotherapy, and he received almost 27 cycles of therapy. After the 10 cycle, he had a great response, disappearance of the lung nodules, very much disappearance of everything, including also the lymph node, the supraclav lymph node, the hilar lymph node. So we did another endoscopy looking at any residual disease. We thought it might show some improvement, but the biopsy still show adenocarcinoma. So he had on the PET scan, post-immunotherapy, I'm gonna show you that he had some changes in the lung, which looks like, okay, it's moving now. It looks like immunotherapy related. If you look here at the interstitial finding at the bases of the lung, it's not malignant. It looks like interstitial or pneumonitis due to immunotherapy. So the only active disease was on the GE junction. So we've discussed it in the thoracic tumor board since we tried our initial radiation therapy and it did not work. And the patient was on immunotherapy for almost 2 years without showing any evidence of recurrence outside the local disease. So the surgeon at that time, since the patient was fit and after multiple scans, we think that he might benefit from resection of the esophagus. Patient delayed the surgery. He was scared from the surgery, but the surgery done in April of 2020. The tumor was T3, no node were positive, and at time of surgery, there is no evidence of the disease. Patient did not come to medical oncology after the surgery. So patient missed follow-up almost like 4 months. Then he came to us with a new scan and PET scan which showed recurrence. We thought that patient, he responded to nivolumab let's put him back on the same therapy. Unfortunately, he did not respond. And due to extensive disease, especially in the lung, the patient performance was not in his best performance status. I start him in single agent Xeloda. And this is his scan. Here, if you can see the lung nodules, multiple bilateral huge lung nodules. And in the liver, it was less than before, but he had like 2 small lesions. So after starting on Xeloda on 6th cycle, this is his scan. Amazing response in the lung. This is what is left from the big lung nodules. Here is just, it looks like interstitial infiltrate. This is a small lesion here, very much clearance of the lesion there. So we go over the journey of the patient. March of 2017, he was diagnosed as a stage 4 with extensive lymph node and liver lesion. We start in chemotherapy, ACX, then again, switch to Xelox, then Xeloda. And after percussion, docetaxel. Then in May 2018, patient received carbo-paclitaxel with radiation. Since July 2018 up till April of 2020, patient was in immunotherapy. And in September, he had a recurrence back to systemic therapy with amazing response to systemic therapy. So the point that I've learned from this case that an aggressive approach for metastatic disease should be super selective. Not every patient we should go all over the way on managing these patients with multimodality, because sometimes an aggressive approach might jeopardize the patient quality of life and even his life. But looking to this patient in particular, the quality of life was excellent. He was driving every day to come to his appointment, and his performance status never changed. It was worsening when he was off therapy. I think this patient with a long survival of 5 years, this is my first patient having this long-term survival, especially on gastric or GE junction, which is an aggressive disease. I think it's a unique pathology. Very interesting to send for NGS and learning more about the biology. Multimodality therapy may impact the survival, and we can see in this patient, he had surgery, he had radiation, although metastatic disease. But again, the patient are still alive. The disease is well controlled with minimal residual disease after all this aggressive therapy. So by this, I'll end. Thank you.
Well, thank you, Dr. Ashwag. Really impressive case that we don't see in our clinical practice, to be honest with you. I haven't seen like a case. I haven't come across a case like this, which is very, very interesting. I would like to ask all the attendees, if you have any question, can you post it in the Q&A box so we can go through. Meanwhile, I may ask one single question before I hand the microphone to my dear colleague, Dr. Fahad. Dr. Ashwag, did you look into, because at the beginning you said that this patient was PD-L1 negative and microsatellite stable, and yet he had a very impressive response to nivolumab. My question, have we looked into other biomarkers predicting response to immunotherapy, like tumor mutational burden or Epstein-Barr virus linked to gastroesophageal cancer? Did we look into any of these factors?
No, that's why I was mentioning at the end, I would like to do like an NGS for this guy, because I think he will have a very interesting, because this is not the usual biology of a disease. You hardly see patients have no sensitivity initially to chemotherapy, then respond to immunotherapy, then back to have an excellent response. And he's receiving Xeloda just 1 gram BID. And sometimes he skipped the dose, he's not compliant. So for me, when I look at his CT scan every day, I think that I'm gonna just let the patient go. I'm not gonna treat him. And he amazes me every time I do scan. So I was thinking seriously of doing an NGS for this patient, definitely.
Very, very interesting. So Dr. Fahad, any comment?
Thank you very much, Ahmed, for covering me. I had some technical problem. But thank you very much, Ashwag, for this very interesting case. I have one comment and then one question, and then I will go to the question from Dr. Nafisa. The comment is, you stated the last statement in your presentation was multidisciplinary may impact survival. I think it does. I think it doesn't may. I think there is no may. And your case is excellent example, as you showed us through patient journey, the systemic treatment with all kinds of systemic treatments, immunotherapy, chemotherapy, biologics, as well as surgery and radiation were always options on the table. And I think that helped the patient a lot. And then my question, do you routinely give a periopicin with the first line regimen that you give? Because sometimes, or most of the times in our practice, sometimes we don't, we just give, let's say, OX or CX. What do you think?
I agree. Now I'm using more FLOT. I know FLOT for metastatic, and even looking at a new adjuvant, I use FLOT. But like apirobicin was one of my favorite drugs since I started looking at doing gastric, and I do see a good response. Not all of the patient, but we know the data that anthracycline, probably the rule is minimal. And maybe this patient, the taxane and the Xeloda, it's the one that make the job, is not the apirobicin itself. I agree. If like as of today, if the patient come to me, definitely I'm not going to choose the same regimen like in 2017.
Yeah, well, one more question, Dr. Schwag. So at the beginning, ramucirumab was not available, but later it was available, let's say 1920. But despite that, it was not, let's say, offered. Did you offer the patient later?
Because Fahad, he was responding very nicely to nivolumab, I cannot stop the medication. He was doing great till we had the surgery. Then everything changed. Whatever after surgery, whatever disease came back post-op, it doesn't respond to nivolumab. When I saw the patient is weak, doesn't want to come to the hospital frequently, Xeloda was the best option. And when I saw the 2 CTs after 3 and 6 cycles, that's more than enough. Let's keep him Xeloda.
Excellent. So we have a very good question from Dr. Nafisa about any evidence supporting local surgery after complete response in the metastatic setting, like what we do in, let's say, in colon cancer. I did not come across an evidence, but I don't think this will render a patient or prevent the patient from some treatment if it's oligometastatic or like only small local disease. What do you think?
I think in upper GI, like pancreatobiliary and also gastroesophageal, the rule of resection, like in oligometastatic, is underdeveloped, like comparing with like colorectal cancer. And probably that's because of the prognosis is poor. And that's why you don't want to invest in these patients doing like a major surgery, then the patient end up with extensive metastatic disease, like you chop part of his liver, and he end up with liver failure because of extensive liver disease. But I think every patient is different. If this patient, when he lives longer, he wants me to do more and more and more. And I think the treatment probably should be, as I said, super selective to the patient, because not every patient come to my clinic would get metastatic gastroesophageal junction. I would think of doing surgery upfront, or that will be in the plan. I will treat him as palliative chemotherapy. But again, every time I tell every patient comes to my clinic, I tell him in every scan, I have a new plan.
We have also, Dr. Ahmed, a good comment from Dr. Ali Zahrani. And Dr. Ali thinks that he was overtreated by radiation and surgery, and he thinks that systemic treatment was enough for this patient. And you know what, in general, maybe I agree with the comment, Dr. Ali, but I think we should take it case by case, and always we discuss in the tumor board. It seems that the patient the treatment plan was driven by the long survival and the response of this patient, right? So when you have a patient who's responding to each level or line of treatment, we feel more courage, right, Dr. Ashwaq, to give even more like radiation or surgery. Yeah,
I agree with Dr. Ali. If this patient have more than one disease in his body, like in the lung, on the liver, and every time like he had a new disease or disappearing in appearance, but the patient was disease-free only on the local regional for 2 years. which was more than enough encouraging to go aggressive and convincing the other party, like the radiation and the surgeon. If we left him in only systemic therapy, would be he alive and well? Probably yes. Maybe he will be fine and he's having a normal life and no problem. Yeah, I agree with Dr. Ali. I think both way, probably there is no right or wrong answer, but I would agree.
Excellent.
Dr. Ahmed, there's a question.
Yes.
Do you want to take care?
Yes. There was an excellent question actually by Mr. or Dr. Anas Al-Ghazi. He was asking about, given the background of cardiac comorbidities in this patient, are you concerned about using anthracycline-based chemotherapy, radiation to the chest area, then immunotherapy, which might induce myocarditis? So are you concerned about these, like the systemic and local therapy toxicities from cardiac point of view in a patient who's known to have cardiac comorbidities to start with?
Excellent question. We'll start with anthracycline. A patient with history of cardiac disease, we did an echo. Echo is fine, ejection fraction is fine, so it's good to go. In terms of radiation, I'm not a radiation oncology, but I think lower esophageal, probably it's away. This is not my area, but I think it's probably lower. I'm not really sure. This is one. Number two, for immunotherapy, all kind of toxicity gonna happen. So it's not an absolute contraindication since the patient have an MI that is stent and he's stable and all his parameter was okay to go with treatment. I think it's a good question that we should be cautious when we're treating this patient if he develop any new symptoms that may be related plus the comorbidity. We should keep an eye, but we should not not giving the proper therapy because we're scared from the toxicity or side effect because it's going to happen anyway, or the patient might die from the disease.
Excellent. I have a question for you, Ashwag, about this interesting presentation about this patient who had different lines of treatment. As far as I can tell, ACX, Xelox, single agent Xeloda, then immunotherapy, then paclitaxel, carboplatin plus radiation, then he had surgery. And he had T3 and 0 at time of surgery. So I have two questions for you. At the time when he had the surgery, would you consider this patient as a cancer-free patient? So would you classify him for any kind of adjuvant treatment? And what kind of adjuvant treatment would you offer him? Because I noticed that you get mad because he didn't show up for a few months. So what kind of adjuvant treatment would you offer as a guy who had all these systemic therapies and local radiation?
Well, Ahmed, I was thinking if he come back again and he is like T3 and 0, maybe hands off because T3 and 0. But if he comes, probably we have a close follow-up. At least we can catch him earlier, or we can help him with other symptoms. Especially when he came, he was having real symptoms from the breathing point of view, which is, I think, probably immunotherapy has an impact because if you look at the scan is not clean, even with this small lesion. So I think we did some harm with immunotherapy, maybe over treating him, but now he's very much a normal person who is coming to the clinic and receiving the therapy with no symptoms, but initially he was very sick.
Excellent. Thank you, Dr. Ashwag. I don't know if you have further question, Dr. Fahad, about the first case.
I think it was a very interesting case. I have no more questions. So
the microphone is yours, Dr. Fahad.
Shukran, Dr. Ahmed. So we move to the next case, and thank you for Dr. Ahmed. Thank you, Ashwag, for giving us a little bit of extra time, so we enjoy more discussion, inshallah. So you are so generous with us, Dr. Ashwag, tonight, and you will also share with us some of your precious experience that we all learn from through a case of hepatocellular carcinoma. Dr. Ashwag.
Thank you, Fahad. And you will have enough for me for at least a few years عشان تطفشوا مني تماما. طيب, I'm trying to share the case. Okay. Probably just give me 1 minute because I have too many things on my desktop. Okay. Okay, very good. So you see the case, Fahad?
Nice and clear.
So this is also another challenging cases, and it's probably, again, treating the patient out of the box. Sharing this is not like advertising to do this for your next coming patient in the clinic. I think sharing the difficult cases is probably to exchange experience, to hear from you guys, and probably you would have one similar case that this presentation might impact management for another patient. So this is a guy who's, again, young, 58, hepatitis B, liver cirrhosis. He was a child B. He's known to have inferior vena cava, multiple thromboembolic, and also DVT, common iliac, and he's followed by hematology, and he's in anticoagulation. Apparently, no clear reason why he's having this thromboembolic, probably cancer related. His performance was zero, no symptoms. Patient walk into my clinic with the LFT was normal, except bilirubin was 91. His alpha fetoprotein was 2,789. He was fit, and in my book, this patient is not fit for any systemic therapy, and he was having a high risk of going into liver failure. So I did an ultrasound and CT scan trying to find why he's having an isolated high bilirubin that might do something like stenting or reducing the bilirubin, so at least I can treat him. So the one who sent him to my clinic, after discussion at the tumor board, he was not fit for local regional therapy because of bilobor disease. And you can look at his scan. Let me see if I can put the laser pointer. You can see here, huge lesion here. And again, you can see the vascularity, another lesion here, a third lesion here. And again, if you see the lesion is occupying very much all the right hepatic loop. So in normal situation, that's what I'm gonna do to the clinic. Bilirubin is a very poor indicator. If you look at the child score, bilirubin is the most important, and that indicate a poor liver. So again, this patient will go for no further therapy. And if we leave this patient 58 not treated, definitely he will die soon from liver failure. So I give him a second chance. I just give him orso and try that might drop the bilirubin to reasonable level. So I might give him therapy. So I give him an appointment in 2 weeks. The bilirubin dropped to 72, still high. So what to do? I was thinking of any medication that can treat without impacting the liver, impact on the liver function. So the first things came to my mind is ramracimab. So I started ramracimab on November of 2019. His alpha fetoprotein dropped after few cycles from 2,789 to 600. And when we did the CT scan, I don't know why this is dropping down. It's supposed to be not full like this. So this is a question for everyone. Can we treat a patient with thromboembolic on anti-VEGF? The answer of this question, looking at all the literature, it's not an absolute contraindication since you are managing his thrombosis very well, unless that the patient have an fresh thrombosis that can affect his life-threatening. So in this patient, he have a chronic thromboembolic. So again, use of ramracimab on this case was not absolute contraindication. Another question come to my mind. He's in anticoagulation and using an anti-VEGF, which can cause risk of bleeding. I think with good monitoring and good instruction to the patient, monitoring his liver function, make sure that you are monitoring the enoxaparin and looking at the platelet. We know the patient with liver cirrhosis, the platelet will drop. You can manage to reduce the toxicity having these two medications together. So this patient is in late B, it's not a child C. So can we treat child C? The answer is no. But again, looking some of the clinical trial, looking at a real life scenario from the guidance trial on sorafenib, that treatment was not have a poor impact on the patient. But these patients with a child late B or child C, they are poor prognostic, so they live shorter. So the treatment will not make their life short. But again, TKI and another therapy in a poor liver is not something we recommend. So here, if you look at the the scan on October, and again, the scan on early to 2020, that was on January. If you look here on the lesion, if you concentrate, it's more of all like a solid mass with high vasculature. If you look at the scan here, it's very clear. It's a more of a necrosis, a good response, and less uptake, arterial uptake on the scan. So it's indicate a good response and even biochemical by alpha-fetoprotein. I think this is a repetition. Okay. So he was having also on the scan some micronodules on the liver, but again, the lesion that I show you on the scan, according to the radiology, have 20% residual viable tumor, and it show a good response, and the other small lesion have no enhancement by the scan. So he had very near complete response on the two small lesion and 20% residual on the big lesion. So we saw the alpha-fetoprotein increase after a couple of cycles, and the patient bilirubin dropped to 56 after the shrinkage of the tumor. Honestly, on the scan did not show any progression, but when we see some increase in the alpha-fetoprotein, we thought the patient now in his best response in terms of liver function and general condition, let's give him more of active therapy. So we thought of giving him immunotherapy. We switched him on nivolumab on March of 2020. He started nivolumab, he received the 240, and then we give him the 480 dose because of the corona outbreak. Unfortunately, the patient progressed. On the CT scan, it showed increase in the disease and also doubling in alpha-fetoprotein from 1200 to 2000. This is showing you the scan from June to August. And again, if you can see the difference between the scan, the lesion is getting bigger. Although if you think the necrosis is more, but the lesion is getting bigger, and also there is small satellite lesion around it. So again, we thought that the patient is still in his best shape, and we get the data from the IMPREV trial 150. Again, since the patient have no toxicity with ramricimab, we thought what's wrong of giving him atezo and Avastin. And again, we give him 3 cycles of atezo and Avastin, and from the first cycle, there's a drop in alpha-fetoprotein to 700. Then after we did the CT scan, the patient progressed. So the other coming question, can we give immunotherapy after failure of another immunotherapy? The answer, we don't know, but there is no data. And probably we would not recommend to use the same class of therapy. But in this patient, the condition is very unique for 2 things. The patient cannot tolerate TKI with his poor liver function. We know the toxicity of immunotherapy is less than TKI, and we thought let's try to give him the best therapy option available. Maybe we can reach the best response before his liver function gets worse, since we managed to drop in his bilirubin. And unfortunately, this patient showed no sensitivity to immunotherapy whatsoever. And again, if you look at the scan here, comparing to here, the liver lesion is getting bigger. And this is another view. And this is also another view of the scan. So again, patient, we thought, let's get him back to the drug that have no toxicity and also have better response in the beginning. And since the patient was off therapy for almost like 8 months, maybe he will have some response. And again, we resume him in October of 2020 on ramrisamab, and we have further decrease on the liver lesion. And this is very clear if you can see the scan. This is the pre, and this is in October, and this is on December. We see more of necrosis and even the size of the tumor shrinking. So the patient, we stopped the ramrisamab in early 2020 because of the poor liver function. We put him in supportive therapy. And again, on February, patient general condition and liver function get better. We put him back on ramrisamab. He had mild fatigue. Alpha-fetoprotein was lingering between the 1400 and 1900. Up till March of 2021, the patient was on therapy. Then I decide, since the patient, his performance status started to decline, to stop all therapy together. So if you look at what's happened in the alpha-fetoprotein during therapy, he dropped from 2,700 to 600 on ramrisamab. Alpha-fetoprotein was increasing to the background on nivolumab and dropped again on atezo, Avastin, but unfortunately this drop was not translated to radiological finding. So this is looking at the patient journey, which he started on November of 2019. Then he received ramrisamab. In 2020, he had a good response. Ramrisamab was resumed again, and we stopped because the patient had one episode of encephalopathy. On March 2020, he started nivolumab. Then the patient had disease progression, started on atezo, Avastin, and held because the disease progression and also some increase in liver function. Again, back on ramrisamab on October 2020 till March 2021. So that's in brief, almost like the patient have like 14 months. He's, as I mentioned, throughout the journey, his performance was good. When we start to see some decline in his performance status, and his liver function remains stable, although some up and down during the immunotherapy, his liver function remains stable. And based off the performance status, we have to stop the treatment, and we will reassess the patient if he's good enough for further therapy or for best supportive care. So, so the teaching point, I think people think about the child score, very important in treatment. I agree, it's very important in treatment, but most of the people are strict that we have to treat child A. No, I think child B up to child score of 7, you can treat. Some of the child score are manageable, you can change, but not all of them, especially the bilirubin. As in our case, it's hard to get it back to normal, especially if it is due to a bad liver. There is no clear data about sequencing therapy on HCC. And for sure, we don't have data on ramrisamab and on the first line on HCC. But again, looking how much this patient stay and survive, although he is, we can consider as a bad patient because of the poor liver function. I think most of the oncologists are underutilizing ramrisamab. So this treatment, I have to say, it's absolutely safe, and it does show an efficacy. I've treated around like 10 patients, and at least the patient who show a response, they will live for 6 months on ramrisamab with absolutely no toxicity from this medication. So again, bleeding and thromboembolic, it's the same story with atezo, Avastin, same story with ramrisamab. There is nothing called absolute contraindication. There is something you can manage, varices you can manage, thromboembolic you can manage with anticoagulation and reaching the balance that you don't get the patient in toxicity because of over treating and causing bleeding or death because of therapy. So by this, I'll end. Thank you.
Thank you very much, Ashwag, for this elegant presentation. This case perfectly match the title of this event, challenging. It's a real challenging case. So I learned another lesson from your presentation, Ashwag, that patients whom we see in our clinic, they're not the clinical trial patients. They're different. So we need to think sometimes not like we're not recruiting to a clinical trial. So you see a patient and you look at the first line options, patient is not fit, then go palliative care. I don't think this is what we should do. I totally support your approach and to look for active treatments that you can start even if it's not listed in the first line options. You also asked one important question that should we use IO after IO? I think we always ask ourselves this question, different tumor sites. We see a patient responding to immune therapy, unlikely, and then we think that maybe another immune therapy will work. So we don't have evidence, but I think we will learn more in the near future about this question. So Dr. Ahmed, I don't know if you have a question to Ashwag.
Muted, Ahmed.
Yeah, I'm sorry about that. Very interesting case, similar to the previous one, as Dr. Fahad said. It's a challenging in nature. I may have a question for you, Ashwag. Why did you consider like ramucirumab specifically in the first line? I know that probably when the patient first presented, maybe the atezo-bev data were not yet available at that time. But how about using nivolumab in such patient? I'm just thinking loudly because nivolumab might be friendly to use even if the bilirubin was high. And we have some data, although it's not level 1 evidence of first line, but at least the data showed some clinical benefit over sorafenib in the first line setting. So what do you think about that? If you have similar case like him in your clinic tomorrow, would you consider nivolumab as a first line treatment?
It's a good thought, Ahmed. But the only thing, I was so scared from the number of bilirubin. Because usually these patients come to us in the clinic as a consultation. You said this is not for treatment and reject the patient. But when you see a young patient in front of you, I was not able to deny him therapy. What came first to me that let's try something light and simple that doesn't cause toxicity. But I think giving nivolumab was not a bad idea. The other thing is that maybe ramucirumab give him more time because this patient apparently have no sensitivity to immunotherapy. So every time he progresses on immunotherapy, and the only drug that works is ramucirumab, and for more than a year.
Yeah, interesting.
Yeah. We had in a previous discussion, Ashwag, about comparing anti-VEGF, ramucirumab, and bevacizumab, about the second line option after atezo-bev. And we had a thought that maybe ramucirumab is similar to bev, so maybe it's not the best second line. But from this case, it seems they're different. The patient responded to ramucirumab, and then he did not respond to bev, although it was combined with immune therapy. And reintroduction of ramucirumab showed partial response. So maybe they're not similar then.
Yeah, I totally agree. This patient is very much unique in terms of response.
Yeah. I may have a question to the panel members here, including Dr. Kanaan, of course, with us. One of my colleagues actually had a patient, HCC patients, and this patient is known to have peripheral arterial disease to the point that he had amputation. Bilateral amputation of both of his feet, or some of his toes have been like amputated because of this peripheral arterial disease, which seemed to be like so serious that he ended up having some surgical intervention for that. So he came up to our clinic with child PUA HCC, okay, in a background of cirrhotic liver. So what is your first line choice in similar patient like him?
I'll give atezolizumab.
Atezolizumab. Aren't you concerned about this arterial?
Definitely, he's
disease?
receiving therapy for that, definitely for his peripheral vascular disease. And maybe I'll be cautious on the dose of Avastin. Instead of 15, maybe I'll give 10. Then I'll see. I don't know about Fahad and Kanaan. What do you think, guys?
I might consider nivolumab as first-line treatment for this patient. But what we learned from the case, it's not absolute contraindication. But maybe to feel more safe, I will go for nivolumab.
Kanaan, what do you think?
I'd give immunotherapy alone. I'd be صراحة a bit more cautious. I'm sure I agree with Shwag. Most likely the patient is going to be on antiplatelet therapy. But I don't think we have data talking about the safety of giving anti-VEGF inhibition with patients who have peripheral vascular disease. However, taking the picture as a full, I would probably feel safer to give the patient single-agent immunotherapy and seeing how he responds.
I totally. This is actually what we did. I mean, I was really concerned about using anti-VEGF in similar case like this because number one, it's an arterial disease, which is kind of more serious than venous, kind of thrombosis. The other thing that this patient had real complication because of that, even before we started treatment, and he ended up having some amputations. So we elected to go for nivolumab. So as Dr. Fahad and maybe Ashwaq said before, that probably this patient was properly managed. We might challenge him with anti-VEGF, but to be honest with you, I was not brave enough to do so. So I elected to go for nivolumab in this patient.
Excellent. There's a scenario question from Dr. Anas Al-Ghazi, and it's away from this case. So if the patient is treated by atezo-bev and is downstage to a level or a point that he's amenable to surgery, so now there's a surgery plan. For what period of time should be off Avastin before going to surgery?
I think 6 to 8 weeks, like any other cases. But if the patient, it depends because HCC, if they think of resection on a cirrhotic liver, they should be cautious 10 times. If the patient is downstage, I would rather go to radiation because of the synergic effect between radiation and immunotherapy rather than doing to surgery.
Totally agree.
Yeah, I had a patient, non-cirrhotic patient actually, and treated with sorafenib, and had, his disease was not so advanced, but it was not good for surgery. So he had some response and went for surgery and had a good survival after that. So that's why really we need to discuss cases all the time. We say this should be discussed in the multidisciplinary tumor board.
Excellent.
Okay. So Ashwag, about the child score, you mentioned that in the clinical trial, it's always child A. We had phase 4 study, phase 3B studies, suggesting that also early B might benefit from some treatments. And we have this for sorafenib, of course. We don't have it for the more recent treatments. Can we apply and extrapolate for the newer treatments? That I do this, I treat early B with Nivo and maybe atezo-bev I will. My partner in HCC here in Dammam, Dr. Leo, does not treat early B. He's so strict to the clinical trial, child A, and I think he has a strong point on this. So what's your practice, Shwaq, Kanaan, Ahmed, in this child B for the newer treatments?
Well, Fahad, if you're gonna treat only child A, you're gonna treat like the minimum of the patient. Mostly they are child early B, and again, you can still downstage them with good therapy by giving diuretic and managing some of the things that you can manage. This is number one. Number two, Kanaan, he knows because he was our fellow. When we collect the data for our patient, most of our patients were child B who treated in sorafenib and have a good response as good as the child A on the CHARP trial. And every new drug, the CHARP trial, they treated only child A, then they again started to do P. And nivolumab, they included early B. And again, you're gonna hear about more patient on atezo-avastin using a child early B. So it's only the beginning. So people will get used to the drug, being comfortable, then they start using it. I think up to child B7, everybody's safe to treat, but monitor your patient very carefully.
That's true. That's true. I may comment on that. To be honest with you, for atezobev, I'm strict to child A. For if I have a patient who's child B, like B7, I may consider starting sorafenib in the first line setting because we have some data documenting that there is a benefit of adding that. On the second line, I may consider nivolumab because, again, there was some data using nivolumab in the second line setting for child B7. There was some, probably all of you are aware of that, the real world data that there was a benefit of using nivolumab in child B in comparison to those who didn't receive this kind of treatment. However, there was like a big kind of difference between child A and child B who received nivolumab. So despite the fact there was a benefit of using nivolumab in the second line setting in child B, but that benefit is very small. And for some of us, we might question the clinical value or the clinical benefit of such an approach. I'm not saying that I wouldn't treat child B, but I would be a little bit on the side of what have been documented in the clinical trials, sorafenib first line and nivolumab at the second line, until we have, of course, more data to support the combination in child B patients.
So I agree with you, Dr. Ahmed.
Excellent.
I am a bit more cautious, perhaps, compared to my other colleagues. For B7, I still do accept them in my clinic, and I would give them Nixabar. And as Dr. Ashwag mentioned, we actually have published an abstract from our National Guard in Riyadh, treating more than 200 patients with sorafenib. I actually published it in 2016. And we did show that patients with B7, they actually benefit. Benefit is better than placebo. However, there is a difference between child A, A5, A6 compared to B7. And I think we expect this. I would not really give my patients atezolizumab in Brave 150 if they are B7 and above. I would think about probably sorafenib because of the availability of evidence.
Excellent. If you allow me, Ahmed, there is a question from Ahmed Raslan to panelists. So why these advanced cases are contraindicated for liver transplant even if they have a donor? So a case of so advanced HCC, they have donor, but we don't send them for transplant. I think simply there's a criteria that these patients should benefit from the intervention that we offer. If they don't benefit, then they should not go for this major surgery for both the donor and recipient. So that's why these criteria were developed, like Milan and MILT criteria. Do you agree with that?
Yes, we do. Yeah. Yes, of course. And just to make a point that these patients are not denied from medical oncology side from transplant, because all of these cases are discussed in a multidisciplinary kind of round. And based on the input of everyone, we make the best decision for these patients. So we are not the one, because the question was phrased as we are the one who are denying these patients from transplant.
Excellent, because all cases really, they come and discussed in the liver tumor board, including transplant patients. And it's the expert physicians and transplant, our hepatologists and transplant hepatologists, to calculate the scores and predict the benefits for this major intervention. I think we dealt with all questions. I'm checking again in the Q&A box. So yeah, so there's a question from Nadam Mahdi. So this patient with isolated high, I think maybe high bilirubin maybe, is he so can benefit from arterial directed therapy as a bridge therapy before immuno? That's a good question.
It's the same concept of the systemic therapy and local regional therapy. These patients are high risk of liver failure, and even higher with local regional therapy. So again, if this patient come with different poor clinical condition, I wouldn't consider going back on the same pathway. What's happened to the patient is just treating the patient out of the box. I wouldn't recommend the same treatment. Again, we have to strict because bilirubin is the worst prognostic feature in terms of the liver cirrhosis. So you have to be cautious in these patients because patients die from the disease. This is the nature of the disease, but we don't kill the patient with therapy.
That's true.
Thank you very much, Ashwag. Mic is yours, Ahmed.
Thank you, Ashwag, once again for this nice, interesting case to be shared with us. And now it's time to move to the third case, and it will be presented by my dear colleague, Dr. Kanaan Al-Shamari, and it's going to be a challenging case of colorectal cancer. So, Dr. Kanaan, the microphone is yours.
Thank you, Dr. Ahmed. Are you guys able to see my slides?
Yes, we do, Kanaan.
Thank you, Dr. Ahmed. So I have to start by thanking the organizers for asking me to present a challenging case. And I have to say I'm disappointed, Ashwag, to present my case after your two cases, because my case is definitely not as complicated as your two prior cases. So I want to go through the objective of this mini meeting, which is to describe approach of complex cases using new diagnostic therapeutic techniques and focusing on multidisciplinary approaches. So I chose a case based on hopefully collecting these sort of techniques or approaches. So I was referred a 67-year-old woman whose initial presentation was to her primary health care with a history of 3 months of bright red bleeding per rectum. She had initially no weight loss or anorexia, no other major complaints. Her past medical history was significant of diabetes and hypertension. Both were actually controlled. She was on an ACE inhibitor as well as metformin. She had no known drug allergies, no significant family. Actually, she did have a family history, which I'll mention later. She was widowed. She had 5 children, and she was from a decent or a good socioeconomic background. So initially from primary healthcare, she was referred to the GI service who have performed a colonoscopy, which showed a large sigmoid mass, which was friable. Scope was unable to be passed beyond that sigmoid mass because of significant luminal narrowing. Biopsies were taken. Now, this patient was not clinically obstructed. Now, she was referred to the general surgery service from the GI service after having had this colonoscopy. And with the GS service, she had a CT of the chest, abdomen, and pelvis. The CT abdomen and pelvis did show the sigmoid mass, and it did show a single liver, most likely metastatic deposit, which was in segment 4, which was 3 centimeters in size. It also, the CT chest did show a left breast irregularity. So this prompted an ultrasound and a mammogram in this 67-year-old woman, which showed a left retroareolar lesion, which is approximately 3 centimeters, which was BI-RADS 5, so highly suspicious. So she went with the GS service, and a biopsy of the sigmoid lesion was back, and it did reveal adenocarcinoma, which was moderately differentiated. We did ask for certain markers. So this patient was MSI stable, RAS, so KRAS and NRAS were wild type. BRAF was also wild type, and HER2 was negative. Now, after discussion in certain tumor boards, which I'm going to mention later, we actually opted to biopsy this liver lesion because we needed to know whether it's from the breast or suspicious breast lesion, or it was from the sigmoid adenocarcinoma. So we biopsied this lesion, and it came back as metastatic adenocarcinoma with immunohistochemical staining, suggestive of a colonic origin. She also went along to have a left breast lesion biopsy, and this came back as invasive lobular carcinoma. Grade 1 hormonal receptors were strongly positive, HER2 was negative, and Ki67 was 5%. Now, I have to say, initially, her performance status was actually 1. So baseline imaging did show this single liver lesion, which was secondary to her colon cancer. So I guess the first discussion point is, how do you approach such cases? So this patient had 2 malignancies. One of them was early stage. The other one was metastatic, perhaps oligometastatic. Can we potentially cure this patient? And we're going to know as we go along in the presentation of this patient. So this patient would fit probably the term of synchronous double primaries. One of them is metastatic. The other one was perhaps early stage. The way probably that I approached this patient was thinking about impending risk or risk priority approach. And I'm going to spend some time talking about this. So this patient actually had discussion at the GI tumor board, where we as medical oncologists present our cases with general surgeons. We also presented this patient at the hepatobiliary tumor board, where we present cases with hepatobiliary surgeons. And a colleague of mine, a breast oncologist, took this case and presented her at the breast tumor boards. I also discussed and co-managed this case with a breast oncologist colleague, because I don't treat breast cancer. So in terms of prioritization of this patient, probably the highest risk of this patient, in my thought, was the risk of obstruction. Remember, the scope wasn't able to be passed. This patient was not clinically obstructed. However, this was a risk. The probably second risk was progression from the oligometastatic sigmoid adenocarcinoma, single met to liver, into becoming widespread metastatic disease. There was also a risk of progression from the breast invasive lobular carcinoma. So again, we presented this patient at 3 different multidisciplinary team meetings, and we had a collective decision and somewhat a provisional plan, which I'm going to explain. So our provisional plan to manage this patient was initially to resect the primary lesion, so the sigmoid adenocarcinoma, as there is risk of obstruction. There was also a significant discussion with some of the general surgeons about perhaps initially putting a stoma and diverting her, and allowing systemic therapy to go to proceed. However, we elected to resect the primary. We also spoke about following the resection versus diversion with some systemic chemotherapy in the form of FOLFOX for at least 3 months, followed by imaging, and then a decision regarding whether to tackle the local disease, so that the liver metastatic disease, at perhaps response. We also spoke about giving this patient neoadjuvant hormonal therapy concurrently. This was led by our breast team. We also had a significant discussion about whether we should do the sigmoid and liver metastatic disease as staged, as I explained before, resection primary followed by chemo, followed by resection of liver disease, versus doing them concurrently, because single lesion, which was 3 centimeters, was actually upfront resectable. We also spoke about following all of the above by modified radical mastectomy. So all of this plan was carefully explained by myself and my colleague breast oncologist to the patient and her brother, who agreed on the above provisional plan. So I want to pause here for a few minutes and talk about approaching synchronous double primaries, because I think this is probably the major learning point from this case. So this is a review paper that was presented in ESMO Open in 2017, and I suggest that the interested colleagues read it. So it spoke about risk factors for developing synchronous or metanchronous double primaries. Of course, we need to think about genetic or familial syndromes. If you have a genetic predisposition, you are more likely to develop synchronous or metanchronous cancers. Now, having a prior cancer and having prior therapy to a specific cancer will more likely predispose you to metanchronous primaries. Examples of prior cancer therapy: if you give radiation to a certain area of the body, let's say, for example, rectum or breast, chances of radiation-induced sarcoma will go up slightly. Certain chemotherapeutic agents will increase your chances of developing certain hematological malignancies, and so forth. Now, certain life factors or certain risk factors do not only affect one cancer and will predispose the patient to developing more than one cancer. Example is obesity with risk of developing of breast cancer, risk of developing of colorectal cancer, smoking with risk of perhaps developing certain lung cancer, squam, small cell, head and neck, certain esophageal, bladder cancers, alcohol, and so forth. Now, the article also spoke about the frequency of having multiple primaries from different large databases. So for metancrinous diseases or metancrinous double primaries, so primaries happening at different time points, the frequency of having those can actually be as high as 17%. The frequency of having synchronous primaries ranges between the level of 1 to 3%. So it is rare, yet we still see it in large cancer centers. So how do we approach therapy of patients with synchronous primaries? So as we have done before, synchronous primaries should be discussed in multidisciplinary team meetings, and a consensus decision on best therapeutic strategy, taking into consideration the best approach with the possible best outcome for a patient, should be undertaken. Also, the patient should be informed about the situation, the complexity of the situation, the therapeutic challenges, and often the uncertainty about prognosis and best approach. Now, there's always thought about which should be approached first. If patients have too localized disease, strategy will be radical, so surgery, chemoradiation, covering both malignancies. If the situation is both advanced disease, so metastatic disease, then we should think about systemic therapy. However, it can be difficult. Most of the time, if we try to give systemic therapy that covers two different diseases, we do not really, or we would not really have a significant amount of evidence backing our decisions from clinical trials. There are certain questions that as oncologists or treating physicians, we would ask ourselves. One of them is, what would be the most significant tumor in terms of progression or prognosis? Is there a chance of a curative approach for both diseases, or should we think about palliative approach for both cancers? If one of the tumor is metastasized or both of them are metastasized, if we think about palliative treatment, should we think about which cancer has worse tumor dynamics? So which one will grow faster and will threaten the life or health of the patient quicker? And what are the systemic therapy options that will cover both diseases? Now, should treatment focus on local or systemic therapy? And can one of the synchronous tumors be treated radically and then the other malignancy be treated sequentially? Which one to treat first? So all of these questions are important questions to be asked by the treating physician. Which problems can be anticipated? So in our patient, we were anticipating bowel obstruction since the scope wasn't able to be passed beyond this large sigmoid mass. So bowel obstruction in untreated colorectal cancer, and hence we thought about either resecting the primary or diverting her with a stoma. Other considerations or problems to be anticipated: if a patient has widespread liver metastases, then liver failure can develop. And I think systemic therapy should address the liver disease earlier. Should we think about doing tumor profiling? So can we think about targeted panel sequencing, so NGS? And could these tumors have a common genetic background? So BRCA, homologous recombination deficiency, PARP inhibitors, and so forth. Now, if we think about systemic therapy for both malignancies, can we choose a regimen that is active for both diseases? If we can't, is there a potential of interaction between two different anti-tumor regimens? Is there any literature backing up our decisions? And can the two malignancies, and I found this interesting to be brought up by the authors, is can they be treated in a cycling manner? And I'm going to ask the panel to give us their experiences about doing this. So can we give systemic therapy for 2 to 3 months for, let's say, perhaps cancer A, followed by systemic therapy for cancer B for another 2 to 3 months in a cycling fashion? So all of these questions are essential questions to be asked in patients who have synchronous primaries. So back to our patient. So we elected, after discussing this patient in the GI tumor board, to have the primary resected. The surgeons also elected to create a stoma. They did not want to do primary connection of the bowel because we were somewhat apprehensive about the presence of liver met, and we were worried about progression and whether this patient is going to develop metastatic disease or worsening of metastatic disease later on. 2 weeks after the surgery, we elected to insert a chest port, and I started this patient on Folfox every 2 weeks. I also started the patient on, or actually my colleague, breast oncologist, Dr. Nafisa, who I thank, started the patient on neoadjuvant letrozole. The patient had excellent tolerance to chemotherapy and hormonal therapy. Now, just as a reminder to the audience and the panel, that this patient liver lesion was upfront resectable, 3 centimeters in a single liver segment. So I did not elect to give this patient anti-EGFR monoclonal antibodies. We re-imaged this patient after 3 months of Folfox, and this patient showed a partial response with a significant reduction of size in the single liver lesion. Now it was measuring 1.5 centimeters. Now I have to say that I was quite worried that this liver lesion may disappear. However, thankfully it did not. So we reviewed the imaging with our hepatobiliary surgeon in the hepatobiliary tumor board, and the surgeon agreed to take her for metastatectomy. They also spoke to the general surgeons, and they decided to do closure of stoma during the same surgery. Now, before she was taken to this large surgery, she actually had a completion colonoscopy, because remember, the scope wasn't advanced beyond the sigmoid. She had a completion colonoscopy done prior to surgery, and we did not find any other suspicious bowel masses. So this occurred as an R0 resection, and she recovered beautifully. She continued neoadjuvant letrozole under the care of our breast colleague, and I actually continued Folfox for another 3 months, hoping to finish her 6 months of total therapy. Now, the patient did report to us that her breast mass became smaller clinically. So after about 4 months after the liver surgery, and after we finished therapy with Folfox, she had re-imaging with a mammogram and ultrasound, and she was taken for a modified radical mastectomy by our breast surgeons. And the pathology came back as T210 invasive lobular carcinoma. Hormonal receptors were positive. HER2 by FISH was negative. Ki67 was 5%. Current status, now this was a couple of months ago. Last imaging showed her to have no evaluable disease, so this patient is in CR. The next visit that she's going to come to us, she will continue surveillance with regular CEAs and colonoscopies and CT chest, abdomen, pelvis within the next 3 to 6 months. And she will continue to follow up in our breast clinic for 5 years in total of adjuvant letrozole under the care of my breast oncologist colleague. She has been referred to our cancer genetics clinic, as she did have some family history of malignancy. She is yet to be seen. So I think one of the discussion points, or these are the discussion points that we can learn from this case, is that concomitant malignancies or synchronous double primaries do require careful planning and prioritization of therapy. Input from different services or specialties is essential. Sequencing therapy based on prioritization, so which cancer has a higher risk of morbidity and mortality, and patient tolerance is very important. Now, timing of liver metastatectomy is also essential. And I put this here because I was worried about whether the liver met was going to progress or going to disappear. And once all of the above is done successfully, it can yield excellent results, such as in our patient who has no evaluable disease and is in CR currently. And by that, I conclude. Thank you.
Thank you, Dr. Kanaan. Really interesting case. Okay, I think we learned a lot about the approach to such interesting cases where they present with synchronous primary cancers at the same time. I have a little question to you, Dr. Kanaan, before we proceed to the other questions. You elected to go with the use of FOLFOX, neoadjuvant FOLFOX plus neoadjuvant letrozole, which is an excellent approach. From breast point of view, we don't like to combine the endocrine therapy plus chemotherapy. I know that we are targeting two different cancers, not the same cancer. On the other hand, the 5FU component of the FOLFOX will work on the breast cancer. So why did we elect to go with the combination while FOLFOX, potentially the 5FU part, might help to control the breast cancer until you have all these sequences of surgeries? Otherwise, I think the plan of whatever plan was delivered to this patient was superb, to be honest with you.
Thank you, Dr. Ahmed. And I wouldn't say I disagree with you, but this patient was combined or did have combined treatment with our breast oncologist, and we elected to give her both therapies at the same time. And luckily, she did have an excellent outcome in the end.
Excellent, excellent. طيب,
especially
yes,
Ahmed,
Dr. Fahd.
Especially, I think 100% maybe they don't respond best to chemotherapy. Although I share with Ahmed the point that we don't usually combine chemo with endocrine treatment.
Excellent. طيب, I have a question from Dr. or Mr. Adil Al-Rashidi. Do you think that NGS should be done initially in all patients with two primaries?
So I wouldn't elect to do that. NGS is unfortunately still costly. It does cost our healthcare system a significant amount. So I usually would reserve it for perhaps advanced, complicated cases where I don't have strong evidence for multiple systemic therapies. So I actually wouldn't do it in patients who are potentially curable, because we don't have evidence for doing NGS for potentially curable patients.
Okay, let's say because your patient is unique, that she presented in a curable status, despite that one of her cancer is metastatic at the beginning. But let's say that the patient, for whatever reason, one of her cancer is incurable. Would you consider doing NGS in this situation?
So I wouldn't comment on the breast component, because simply I don't treat breast. But for the colorectal component, I have done the markers that we typically would do for metastatic colorectal cancer. I think this is the bare minimum that we should do, which is MSI. There is evidence for frontline immunotherapy in patients who are metastatic, KRAS and NRAS because of the evidence of anti-EGFR, HER2 and BRAF because they may have prognostic or predictive value for anti-EGFR if patient is RAS wild type. And they do have targeted therapies in the second line therapy or beyond. And this is in anticipation that this patient may not be curable once we actually give her FOLFOX. So I think doing KRAS, NRAS, MSI, HER2, and BRAF is the bare minimum that we should do for metastatic colorectal cancer. Perhaps I wouldn't do NGS unless patient perhaps progresses on at least 2 or 3 lines of therapy. Performance status is still excellent, and I anticipate that she would be alive in more than 3 months. Then I would think about doing NGS.
Excellent. What do you think, Dr. Fahad and Dr. Ashwag, about this approach? I mean, using NGS for those people who present with 2 primaries, would you go with Dr. Kanaan approach? You stick to the standard kind of test that we do in our day-to-day clinical practice? Or would you say this is an unusual kind of situation that needs unusual way of approach?
I think if if this is different than this case, this patient have potential treatment approach and she was treated for curative intent. If she's like having more an advanced disease and we're treating more of palliative intent and try, because if this patient have more like both are metastatic disease, like the breast and the colon, maybe we will be very short of therapeutic options. At that time, maybe I would consider NGS, but if do I have a good therapeutic option available, I wouldn't think of NGS in every single patient, because having dual malignancy is not uncommon. We see that, and I wouldn't like have generalized this. But if it is a standard in the hospital and it's available, having this part of information definitely will add a value for any patient.
Excellent.
Yeah.
Dr. Fahad?
I agree with you. It's a bonus value information that maybe doesn't necessarily affect the treatment plan. So not in all patients. I have a question, and Ahmed, maybe you can help us with this question.
Sure.
What is the recovery time usually after mastectomy? From what I think, it's not so much. They heal quickly. It's unlike colorectal surgery. I was thinking, Ahmed, if this patient was 3 centimeter resectable, she should do mastectomy, heal within a couple of weeks, and then you are free to approach colorectal. What do you think?
Yeah, I agree with you, Fahad. I mean, in uncomplicated breast surgery, I would agree that within 2 to 3 weeks, most of our patients, they are fit to go for whatever systemic therapy you may suggest. However, in these rare cases, I wouldn't say rare cases, but I would say uncommon cases, where they present with some sort of post-operative complication, like seroma collection, and like infection of this kind of seroma, which might needs like prolonged time of post-operative kind of follow-up and treatment, antibiotic treatment. This may jeopardize, in Dr. Kanaan case, might jeopardize starting new adjuvant treatment for the metastatic colorectal cancer. So I totally concur with Dr. Kanaan and his team approach that probably we have to focus on the metastatic colorectal cancer at this point of time. And given the fact that this kind of breast cancer is typical luminal A with a low Ki-67, with a strong ERPR receptor status, it can be really controlled with hormonal treatment even for several months to go. So I think if I want to prioritize, I mean, which kind of cancer we should start with, I'll put metastatic colorectal cancer, as my colleagues did.
Excellent.
Excellent. I have a question actually from Dr. Ahmed Raslan. Why didn't we go for synchronous liver and colon surgery from the start as one of the treatment approaches listed in NCCN? Why did we do it as a staged kind of surgery?
So excellent question. I think this is an important question to address. طبعا even in NCCN they do speak about staged surgeries. It is still a well-known approach in the guidelines. Now the reason we elected to do it in a staged fashion, because there's always a risk, albeit small risk, in standard colorectal cancer, that these patients may actually progress on systemic therapy. So testing the biology of the cancer, I think, is important by exposing them to some systemic therapy, because doing this major surgery in one go does carry a significant morbidity risk. And if the patient does progress immediately after surgery, I do not think that we would have done the patient any benefit. So I think testing the biology of the cancer is perhaps maybe a safer and a better approach.
Excellent. Dr. Fahad, the question in your center, what is the best approach in your center? I mean, what is the most common approach if you have a resectable liver metastasis upfront? Would you go for upfront like synchronous kind of surgery for the primary and the liver metastasis, or would you do some sort of new adjuvant chemo, as Dr. Kanaan said, for testing like the biology of the cancer? What is the
Yeah.
approach in your center?
Yeah, thank you. So it's always a discussion in our group what to do. Sometimes we do combined, but that's not the usual. You need like a fit patients and some circumstances. Otherwise, the discussion is always primary first, liver first. And always they discuss our surgeon, the hepatobiliary and the colorectal surgeons about different things. But usually we do either primary or liver in one surgery. Later on, they do the other. Sometimes we do the primary, neoadjuvant, then liver. But always liver, if it's like 3 centimeter or even 2 centimeter, we go for chemotherapy before. So if there's obstruction or something, you want to deal with the primary first.
True. That's true. Excellent. I have one last question here from an anonymous attendee. In this patient, letrozole and Folfox are given together. How much is allowable to give hormone and chemo together? Dr. Kanaan, I mean, using this combination between hormonal treatment and chemo, for how long should we go with this kind of combination?
So we opted to give the patient or to treat the patient in a staged fashion. So I think doing disease assessment scanning and clinical assessments in every 3 months is perhaps what I would do. So not exposing the patient on hormonal and concurrent chemotherapy for a very long time. I think we did achieve a good outcome. Regarding how long we can continue patients on hormonal and chemotherapy concurrently, I'm not really sure what the right answer is.
Dr. Fahad, Dr. Ashwag, any comment about this particular question?
I think we should not compromise. The patient received hormonal plus chemo, did well. So I think the patient should complete, or should have completed, of course, the whole course of chemotherapy for colorectal, which is not like forever, right? So it's for a certain period of time, maybe neoadjuvant, then you complete 6 months of treatment, and then that's it. Then she can continue for the adjuvant hormone treatment.
Excellent. Ashwag, any comment about this?
For me, like for how long, I don't have no idea for how long, but I'm not really sure. Do we have data? Probably Ahmed, you are the best person who can answer because you're doing GI and breast. What do you think?
Yeah, I mean, the question is fair. I mean, for how long? As clearly, like mentioned, correctly mentioned by Dr. Fahad and Dr. Kanaan, for the neoadjuvant part, we'll go with the combination. I mean, until the liver lesion or the decision to make liver surgery is done. And the shorter will be the better. Like if we do it like within 4 cycles of chemotherapy, then the patient will go for surgery. And afterwards, the patient will continue the remaining number of cycles of chemotherapy. So if he or she had 4 cycles before surgery, it's gonna be 8 cycles afterwards. So the question, I mean, for how long? I don't think there is like any data or evidence to support any kind of answer here, because we rarely see such combination of 2 primaries at the same time. But if this patient is mine, I would do exactly what had been done with Dr. Kanaan and his team. And the outcome, as clearly mentioned by Dr. Kanaan, was really superb there. Yeah.
So I have a question for the panel, if I may, Dr. Ahmed.
Yeah, go ahead.
Since all of you are GI oncologists, would you, since this patient was upfront metastatic, although it's a single liver lesion and resectable, would you consider giving this patient anti-EGFR monoclonal antibody with chemotherapy or not?
From my side, I would not give this patient anti-EGFR, simply because I think it's resectable. It's neoadjuvant, and if the treatment is neoadjuvant, we have some evidence that doesn't really add a benefit as neoadjuvant. If it was like a conversion chemo, maybe I'll give it a try. But for neoadjuvant, we don't usually give anti-EGFR, and I think we do not need it at this.
Yes, I totally agree with Dr. Fahad. If the patient is resectable, I would go with chemotherapy, as you correctly did. If I'm looking for resectability, like as a conversion, because the response rate will be augmented by adding anti-EGFR, so I would do that. But in your case, I wouldn't.
I would agree.
Excellent.
And one last question, sorry, Ahmed.
Yes, sir.
we don't always stay with experienced oncologists, so that's why I'm asking some of these questions.
Sure.
Is what would you do if this single liver met disappeared? I was actually worried that it may disappear. And it did reduce in size by 50% after 3 months of therapy. Now, I thinking retrospectively, I would have probably imaged her after 2 months rather than 3 months of therapy because of this sole reason. But what would you do if this liver lesion disappeared?
I will tell you like two quick stories, like 2 patients of mine. One of them presented with 2 liver lesions. One of the lesions is bigger than the other. And we started new adjuvant chemotherapy. It was exactly at the time when the corona crisis, hit the country. So all elective surgeries were like on hold. So we elected to start this patient on chemotherapy. And after 4 cycles of chemotherapy, one of the liver lesions completely disappeared. Okay, the patient was taken to the OR. Even with intraoperative ultrasound, they couldn't pick up the other liver lesion. So they did resection of the visible one, and they left the other because they couldn't see it. So we completed the remaining cycles of adjuvant chemotherapy. And after, like I would say, 8 months of surveillance, I kept him on active surveillance, like every 3 months, like CT scan, because I know that this liver lesion will show up. Exactly after 8 months, it showed up on CT scan, that liver lesion, which was missed before. So we took the patient back to the OR and we resected that. He's now almost, I would say, 6-7 months off that surgery, and he's cancer-free till this point. Another, like a quick patient of mine, he had a small liver lesion to start with. He was rectal cancer, and it was locally advanced. So we elected to go for new adjuvant concurrent chemoradiation. The liver lesion was like small, like around 1.5 centimeter. So the risk that this liver lesion will disappear with this kind of course of like chemoradiation is really there. So what we have done, we did something outside the box. We did RFA of that liver lesion. So we went for concurrent chemoradiation. And after he had rectal surgery, the hepatobiliary surgeon, he went after that lesion as per the RFA scar. And he resected that point, and it was like a complete necrotic tissue. There was no viable cancer cells. So these are the 2 patients that I would. So to answer your question, if that lesion disappear, what I will do, I'll keep the patients under like aggressive kind of surveillance plan until that lesion show up again.
There is another approach, because some of the surgeon, because the liver, you can divide it into segments, so they will go and resect that segment, because around 30% vanishing liver disease, they have residual disease. So whatever Ahmed did, it's excellent. Probably this is, most of the surgeon will tell you, no, I'm not gonna touch it since there is no liver lesion. But if you have a brave one who can go after that lesion, that would be another approach to add to what Ahmed said.
Excellent.
It's a dilemma that disappearing liver lesions, and it's always a discussion with surgeons, as Ahmed and the Shwag stated. If you don't see it, you cannot even intraoperatively. I'm not sure that resection helps the patient. Probably it will decrease recurrence, as the example of Dr. Ahmed, but maybe this patient will recur anyways, even if it was not disappearing, it was resected. So we do not have evidence that resecting the site of the disappearing lesion will improve survival. I would think that the best approach is close surveillance and resection whenever required, and maybe giving more of that treatment because it's so sensitive.
Excellent. Excellent. So I will conclude with 2 last questions quickly. One of them from Dr. Nada Mahdi. Was this patient tested for Lynch syndrome? This is from Dr. Nada Mahdi. Another question from Dr. Ahmed Raslan. What is your next step for maintenance therapy for both breast and colon cancers?
So was this patient tested specifically for Lynch syndrome? No. She did have some family history of other malignancies, and I have referred her for the genetic clinic, and she is yet to be seen. Regarding maintenance therapy for colon and breast, there is no maintenance therapy for colon because she is disease-free at the moment. So we don't usually we don't give maintenance therapy if someone has no evaluable disease after resection of primary and metastatic disease. With regards to the breast, she will continue to follow up with my colleague who joined us now as a panelist, Dr. Nafisa, probably for 5 years with letrozole.
Excellent, excellent. So with that, I don't have any more questions. Dr. Fahad, the microphone is yours.
I just want to congratulate the organizing committee for this event because the settings of this activity, to hear about these challenging cases and to have this very excellent discussion for these challenging cases, which we will not hear about in our meetings. So thank you very much for the organizing. And Mike is back to the, I don't know, Ashwag?
الله يعطيك العافية فهد وأحمد وكنعان
الله
يعني
يكرمكم إن شاء الله.
you made the meeting يعني you made it good with the nice discussion. I was very happy and pleased. Yesterday was also an excellent meeting and the attendance is very good. So I would thank all the attendee for having during Ramadan and you're attending this meeting. So promise that all of you senior oncologists and whenever you have challenging case, please come to us because we're planning to do this more frequent, very simple, short meetings, and it will educate a lot of people into the things that not usually in the POCS or in the clinical trial, that in the real practice. So I'll thank you all. Thank you for joining. Thank you for the attendee. Thank you for our help, Marie, Jason, Hanan, and Mohammed Khayat. And we'll wish you a good night. تصبحوا على خير.
Thank you very much.
مع السلامة.
الله يحفظكم.